name's Tony Betts. I'd like to thank the Rigo Concept for being invited to a Dr. Rigo Invites series to discuss, and I title, The Evolution and Scientific Evidence of Side Shift Therapy in the Treatment of Idiopathic Scoliosis. If you'd indulge me today, what I'd like to do is discuss the influence and impact of my mentor, Dr. Min Mehta, one of the giants of the scoliosis world, who I think needs to be actually given more appreciation of her role. I'd like to discuss how side shift therapy is advanced with the help of Tori Miriami and my own way in developing pathways and classifications to produce a coherent.
Hi, Tony.
All right, sorry, what went on?
Don't worry. Do you want to? Okay, can you start again with your presentation? Okay, let's go.
We start when the side shift system was approached or developed, and this was by Stendler in the 1930s. He described the classification of functional and compensatory corrections, which could be applied as repetitive exercises to balance particularly the coronal posture of the spine. And his concept there was if the structural rotation of the scoliosis could not be corrected, then at least the mobility of the curve could be maintained, which would help operatively, but also that the trunk could be balanced in the midline. This was developed by Min Mehta, and who developed and added the sagittal plane with the guided trunk shift and pelvic tuck. Tori Muriami added the pelvic hitch technique to correct lumbar curves, and I further developed clinical classifications and standards related to its application. Min Mehta, she went to a native Calcutta, she was born attended medical school there. During her training, she was interested in surgery, initially neurosurgery, but fortunately for us in our world, she later went on to become into orthopaedics. This was not easy, although she was the second woman in history in England to win the Robert Jones Prize and a gold medal in orthopaedics for her work on infantile scoliosis. It took her some time to get this published and for this work to come along. The meta-rib angle, which is one of her primary great ideas, was the idea that the angle related to the concavity and the convexity of the curve related to the midline could tell us something about the progressive qualities of the scoliotic curve. Her main idea was the principle of using the child's growth as a corrective force in eradicating the deformity. When she moved back to England from India, she served as an honorary consultant at the hospital, and I worked with her for about 10 to 12 years. And she continued her research in this area. She was particularly interested in infantile, juvenile, and early onset. She herself had scoliosis. Her publications include early treatment of infantile scoliosis and the role of growth as a corrective force in 2005, where she used a TLSO. She developed the method of casting and continual application and reshaping of the child's torso. She considered the importance of the rib angles as well as the side shift as being important in order to get the best possible correction. She did a prospective study of these infantile scoliosis, looking at 136 children, which was published in the Journal of Bone and Surgery. What she found was in this group of children that the mean angle of the scoliosis could be maintained on smaller curves, if not slightly corrected, but in higher curves, with Cobb angles of over 52 degrees, it could not be corrected or reduced. But in some cases, it could be stabilized. She looked at the role of the rib angle within this and found that angles over 20 to 25 degrees of rib angle rotation were more likely to be progressive. Steinler in 1920s developed his compensatory treatments. He believed that counter-compensatory curves in a movable part was what corrected the alignment of the scoliotic curve, and that it was unlikely to be moved at the area of severe deformity. He produced photographic evidence of the compensatory treatments from the relaxed state to active mobilizations, the first time considered the activeness of corrective techniques as a way of shifting and bringing the head and the trunk more in line with the pelvis. Min-Meta wrote further on this. She described, the side shift is taught in a clinic and is easily learned. Most children become adept in a matter of seconds with the aid of visual feedback provided by full-length mirror and gentle fingertip pressure lateral to the convex side of the rib cage and the contralateral hip. She defines the period herself when the realization that frequent repetition of this maneuver can stabilize it, when she had a girl with a 28-degree thoracolumbar curve and a RISA grade 4 who managed with repetition to reduce her curve by more than 5 degrees. She continued to study this over many periods of time. Not only did she look at growth as corrective technique in these clinical research, but she also did basic research looking at the solubility of spine ligaments, the characterizations of collagen from normal and scoliotic, to try and define what might be some of the non-bony components of scoliosis. Tori Murayama, he added the hitch technique to try to improve the lumbar curvature on people with double curvatures. Again, he showed correction could be applied through radiological means, but also showed that he assisted an application of instructions throughout the day that the curvature could be corrected. These radiological side shift corrections were defined by both Murayama and Min-Meta, and her case series reports on these over significant periods showed that with the right application of repetitive techniques throughout the day, the curve could at least be stabilized and reduced the actual rate of progression on those that are most likely to change. Again, she produced case series reports on these, looking at the correlations and comparative studies of what happens at different ages and how the Cobb angle could be reduced or maintained. What she found in this study was that the lumbar, lower thoracic and thoracolumbar curves were more amenable to side shift and pelvic tuck than the more aggressive specific thoracic curves. So how does it work? She wrote a little bit about this and her theories of how the curvature developed. She believed that a slight tilting of the lumbar curve later with the development of a lateral curve tilted the vertebra towards the lower end, which forms the base of an oblique stack of 2 or 3 curvatures. This oblique stack was the area that we should be targeting to try and correct the deformity. The lower vertebral tilt increases and leads to the progression of the curve as it moves away from the midline. And the idea is to move this oblique stack by opposing it at the point of action by the child's own muscles across the pelvis trunk, so it becomes overcorrective. We can see this defined schematically here, where we can see the targeting of the lower vertebral tilt as a means of trying to correct or straighten by horizontalizing the disc and the vertebrae. And this is a very important biomechanical principle on which the side shift overcorrection therapy works. You can see where it might be directed from a radiological point of view with the applications of rotationary and unbending and elongation to that. And here's the application of that technique by somebody who has a mobile curve. Biomechanical analysis by people such as Stokes has looked at the cost of this strategy and that how side shift exercises corrects the symmetry and brings it more in line, but this happens at a high cost of activity, and that's important for us to understand. Altered movements in scoliosis have been looked at by Sherardu during the dynamic side shift, who has shown that the weight and speed of shifting alters in people with scoliosis too. W.A. Boyer looked at the clinical evidence and compared it to a historical brace treatment using the same methodology, and found that the FST 66 versus 68 and the FSE, looking at 95 to 90%, there was minimal difference between the two methods. I myself have tried to further develop this and modify it, looking at protocols, a classification of how mobile a curve is and when it should be applied, looking at different ways to apply it from biofeedback techniques, adding through the SOSORT guidelines, looking at the breathing mechanics, particularly around the ribs, adding modern day trunk stabilization and Pilates type treatments to it, and advocating more night bracing when applicable. We've tried to look at it biomechanically, looking at the ultrasound analysis and looking at what happens to a curvature as it corrects. What we've found is that we can see alterations in muscle activation patterns, in the alignment of the laminar and the spinous process, and so while you shift in the trunk, you're getting a coupling of the correction by a derotation with the unbending of the trunk shift. And the coupled mechanics is important concepts that underlines this application of hypercorrection. We looked closely at photographic and again more still images of the ultrasound to show correction and alignment of the spinous process during this trunk shift movement. We use EMG and biofeedback techniques to correct. Side shift research continues with places such as Korea, Japan, continue with Toru, and in Spain using the shoe lift as a way of correcting both curvatures, and it's an important element of the different forms of schools of scoliotic deformity. We believe it falls clinical implications of side shift approach. Its outpatients and its minimal intervention, its cost effectiveness and accessibility make it an important component or more tool in the different types of treatment for scoliosis. Further research is needed to do, particularly on randomized controlled trials, to give it greater scientific validity. These trials need to be over long periods of time, so we can see a reversal of the curvatures. And again, further research looking at the basic science into what hyper or overcorrection does to the curvatures, the soft tissues and the muscles. A few quotes from Min Mehta. The trick is to learn to look critically at each child and understand how it can be assisted. The earlier you treat the child, the greater the chance of making them straight. But all children are different. Their build, tissue size and shape vary. Some can be straightened completely, and for some, it may be too late. They're like drooping flowers. Thank you.
Thank you very much, Tony Betts from London, from United Kingdom. And again, Tony, so sorry for these technical problems. At the beginning, I didn't have, or before your presentation, I didn't have the opportunity to introduce you to these technical issues. And I would like to go again and to introduce you after this nice presentation. And thank you very much for all the work you have done during more than 30 years as a physiotherapist at the world-renowned Royal National Orthopaedic Hospital, working as a spinal specialist for pre-operative and post-operative scoliosis patients. Also, you did a mention, thank you for 15 years working with MIM-METHA, helping to develop the side shift therapy. Nowadays, you are founding member of SOSORT, and I would like to remark one thing, Tony, that you are passionate about treating all forms of scoliosis with minimal effective intervention in unknown patients. Tony Betts, thank you very much for your collaboration,